Wilkinson. I'm a psychologist who works at the...
We can't hear.
Oh, you can't hear. Can you hear me now? Okay. I'll lean. Hello and welcome. My name is Poppy Wilkinson. I'm a psychologist who works in the Personality Disorders Program at the MUHC. And tonight, in collaboration with AMI-Quebec, we are thrilled to welcome Dr. Lois Choi-Kain, who will present her talk, Good Enough, Family Tips. Dr. Choi-Kain is the director of the Gunderson Personality Disorders Institute of McLean Hospital, an assistant professor of psychiatry at Harvard Medical School. She's an active researcher on BPD and an expert on evidence-based treatments. She is also passionate about educating others and sharing her expertise. Her talk tonight is intended to provide practical advice for family members whose loved ones struggle with BPD. I would like to warmly thank Dr. Choi-Kain for being with us here tonight. I would also like to give a thank you to everyone else who helped bring this event to life tonight, and especially Lise Laporte. Just a few announcements before we get started. Dr. Choi-Kain will be answering questions from the audience who are here tonight. However, for those joining online, unfortunately, we are unable to receive questions that are sent online. If you sent questions beforehand, Dr. Choi-Kain will attempt to answer as many as possible. And finally, a note that tonight's talk will be recorded. So thank you, and I look forward to hearing this talk.
Hi, everyone. Can you hear me? Is this better? Let me move this up. Is that better? I'll try to be as loud as possible. Some people don't think I have that problem. But it's really good to be here with family members of people who have BPD, because you're really on the front lines. And I think the very same kind of ideas, concepts, and tools that clinicians need to be helpful to patients can be helpful to those closest to people who have BPD. So my main goal here is for this to be useful. I have a lot of material, but I really would love to hear from some of you. I have some of the questions that I've received to integrate into my comments today as well, because I would really like to keep this kind of interactive as possible. Just by a show of hands here, how many of you are parents? Okay, and how many are siblings? Or partners, or people with lived experience? Okay, great. Well, I'm going to actually give this talk from a variety of perspectives, so feel free to unmute it. Can you hear it now? Okay. Feel free to jump in when I have some time for questions. So I'm going to talk about good enough family tips, just to give you some tools to manage the moment. It doesn't mean it's going to solve problems, but it will give you a ground to stand on, to think first before you act. And the main goal is to hold on to both sides of the situation, what's beneficial or helpful about it, or what you can learn from it, not just the outcome at hand. Today, in preparation for this talk, I was thinking about just the developmental process that we all go through. I really think about borderline personality disorder and all personality disorders as developmental disorders, meaning that I think people can learn how to live with different sensitivities, vulnerabilities, and strengths and weaknesses over time. And our personalities adapt to contain the challenges that we face in life. And family members are no different, that we as parents or caregivers also go through a developmental process. So there's this kind of common knowledge that when we look back on early life of our kids, we look back on it fondly, even though it could have been a hot mess. I don't know about you, but when you are raising little children, it is a constant struggle to learn how to manage the challenges and get on top of all the responsibilities. But when we somehow look back on that, we think of it so fondly, as if that's a time that we want to recapture. And while the dependency of our children is really high in their early life, the satisfaction is also very available. But what happens as people emerge into adulthood, which people with personality disorders are kind of in a prolonged state of doing, parental satisfaction and fulfillment declines with the growth of the child and their need to take over their own lives. So the responsibility we have to solve problems diminishes, but the desire to solve those problems doesn't do so, and that's the parental struggle. So we have to, as caregivers, cope with our helplessness while needing to step aside and watch young adults emerge to deal with life's challenges on their own terms. And I really encourage you to think about that as a process of developing one's own personality. And in that, we have to somehow accept the suffering and the inabilities they face, and the inability we have to shield or protect them from the challenges they have. So we all need to kind of band together and support each other in this, because there are ups and downs to the process, even though we wish that we could keep it on the up and up. And a lot of families will say, oh, I just want my loved one with BPD to be happy. And sometimes I say, wow, that's really ambitious, because happiness is hard to maintain for all of us. And this is actually a piece of research that was done on people in a large health system, showing age and its relationship to life satisfaction. And actually, life satisfaction starts to go down in the teen years, and then it hits its depth at the time that a lot of people are having children, because life is challenging. Trying to establish your careers, raise a family, and cope with your own adulthood is very hard work. And actually, the satisfaction people have with life starts to increase. That kind of coincides with kids growing up and leaving home. So this is a time that there's more space for oneself as they grow up and their children grow up. And then they actually find that they can do things according to what they want to do, what's meaningful to them, rather than responding to life's demands constantly. And in that process, we learn to accept the laws of life. That is, the disabilities we have, we all have disabilities and limitations. The failures we face, we all face failures, and we can't protect people from that, and the losses that we'll all endure. And I want to just remind you all that our personality forms in the face of these adversities. So trying to protect people from adversity is actually going to interfere with the normal development of their kind of personality process. So moving on to what helps in treatments, I want to start with the basics, because all psychotherapies are founded on some common features that make them helpful. First of all, they have these concepts that I'll review today just as a framework that depersonalizes the situation. They're concepts that make hot things cool off to handle them. They help you be a little bit clearer in your thinking and more objective. And it promotes a more constructive story about what's happening and the hope that something can be helpful, okay, in the face of things that can be overwhelming and feel demoralizing at times. And what you can do with this is then kind of take root in this structured way of establishing a relationship based on goals. What are we working on here? And this also provides a predictable and stable foundation for the person with BPD to gain awareness of the factors associated with their difficulties. So being consistent, being clear, taking your time to communicate and respond to your loved one with BPD is really the key here. None of us are superhuman, and none of us are perfect all the time. And lastly, I think that this is the punchline that I really want everyone to keep in mind, is we want to emphasize what's realistic, what we can all maintain, and what we can all kind of allow our loved ones with BPD to face over time with increasing capacity and competence. So I'm going to move on to the models, and I'm just going to boil them down so that you can think about some concepts that might help organize and stabilize you in the face of certain difficulties. So starting with dialectical behavioral therapy, this is, of course, a very effective, well-studied treatment for borderline personality disorder and other disorders that involve emotional dysregulation. And it really shows the transaction between someone born with certain features, like emotional sensitivity. We're all born with different sensitivities in life, and they are things that we have to learn to manage over time. Because most environments aren't well suited for our sensitivities. So whenever we have a sensitivity, like something like emotional sensitivity, we're gonna face stressful environments that are overwhelming, triggering, and difficult. The problem is not that. It is that once that person with emotional sensitivity faces an environment that does not tailor its responses to their specific needs, this person can become hypersensitive because they expect to face challenges in a lot of different scenarios, and they start to lose self-esteem and a sense of adequacy in the face of normal life difficulties and challenges. And what happens is a transaction with other people around them where there's a lot of blame and denial. So not only is there emotional hypersensitivity, but there's this interpersonal instability. And because the parties can't relate to each other and understand each other's positions in this dynamic, it's really easy to get into a situation that's solution-focused instead of empathic. And so that sets up the person with BPD to want solutions for their problem, and the caregivers to try to seek to take care of things. But this becomes an endless struggle. So what DBT proposes is a number of skills to intervene to manage the emotional sensitivity in the face of what's expected to be an invalidating environment. Okay? The goal is not to get rid of the invalidation completely, although you can do a lot to provide validation along the way of the difficulties. But the way I want you to think about these skills is just in terms of their functions. With the skills of mindfulness, it's just to kind of slow down and try to pay attention to what's going on. Separate what's coming up for you inside your thoughts and feelings from what you see going on around you, what you see is going on with your loved one. And make sure you kind of can keep those separated in your mind because they're not always the same. Then there's distress tolerance, which is just basically trying to wait until you're less distressed so that you can be at your best to respond. And that really helps you to not do things that make it worse. Emotion regulation is about taking care of yourself in a way that keeps you steady. That is, get enough sleep, eat nutritious food, curb your alcohol and drugs, and try to create positive events and mastery in your life so that you can stay stable. And this is among one of the most important skills for caregivers. And lastly is the realm of interpersonal skills. That really has to do with being effective with people rather than trying to get a certain response from them. What can you do to feel like you're being effective towards what you want and what you think is important, regardless of the outcome? So the way that this helps is to really help you think about your loved one with BPD as having problems of emotional hypersensitivity. When you have an unstable sense of self, an unstable personality, it's like having a kind of one single layer of skin when everybody else has 7 layers of skin. So that layer of skin is working very hard to contain everything within, and it's easily injured because it's not very reinforced. So what you can do with this to provide some reinforcements and some buffer is use skills. That's one model of how you can help someone. And this helps them achieve growing effectiveness towards goals and values. And that's what ends up repairing one's self-esteem. As you go through life and take on life's challenges, whether you have a good outcome or a negative outcome, you learn something about yourself along the way. So helping people go forward despite the bumps in the road and use skills and develop a sense of self over time that improves their self-esteem is really the outcome we're looking for. But it's a long path. There are many treatment models that work for BPD, and I want to emphasize that there's no right way. But these are all tools that can help you think about things in different situations to help you through the storm. Now, mentalization-based treatment is a treatment that's come out of the European side. It's based on the idea that borderline personality disorder is a disorder of disorganized and insecure attachment. And what that means is that there's a need-fear dilemma for people who have BPD where they really need the person that they seek care from, but they're also really afraid. So they send these attachment bids that are very contradictory and confusing, and it makes it very difficult for other people to understand what the person needs and what's going on for them, and then respond in a benevolent way. And this process of having an insecure and unpredictable attachment style also makes it hard for people with BPD to learn how to accurately and flexibly understand themselves and others in interactions, okay? And because of those two areas being so unpredictable, that is attachment and mentalization, it becomes more difficult for people with BPD to learn from the social world because they're constantly feeling hypervigilant and on guard about what's going on. They don't know how to calculate predictions of social interactions. So this is how this works, is that in an attachment process, children who are not yet great at expressing themselves verbally, they have a repertoire of behaviors that are developed so that they can get the attention of people who are taking care of them. So a child in distress just instinctually makes a bid. They usually cry or express distress in a certain way to their caregiver. And the caregiver's job is to provide a kind of mirroring that's both reasonably accurate, but also conveys, this is my understanding of you. So it's somewhat metabolized. Okay, so when a child cries, it can be very upsetting. So it's very important that you don't just start crying too. So that would be unmarked mirroring. But the marked part is that you're representing to the person, the young child, what it is you think is going on with them. And it's in that metabolized representation that that child can develop a more clear psychological understanding of themselves. And that actually gives them a sense of coherence. And this is a process that really emphasizes that as important people in the lives of someone with BPD, you can actually do a lot by trying to understand their situation and conveying what you understand without doing anything at all. And if you can do that, that provides them a little bit of reinforcement for their kind of psychological skin, their personality, and they may feel more contained just from that alone. But the thing you have to be careful about is that people with borderline personality disorder also get very hyperactivated in attachments. So the way that disorganized attachment works is that when a person is distressed by an emotional challenge, this brings up mild distress and anxiety in all of us, right? And that causes us to do something called proximity seeking. We try to go near people that we think can support us, and this activates the attachment when we send these cues that we need help. But the way that people with BPD send these cues, by either harming themselves or lashing out, this becomes emotionally challenging to caregivers, right? And then that actually causes them to react to the person with BPD in a way that undermines their ability to think. So you want to actually keep things cool and not too activated, try not to get too over-involved, so that the person with emotional and interpersonal hypersensitivities can have some room to metabolize what's going on and stop and think. So the way MBT works is that it really works to just stabilize an understanding of what's going on, some curiosity about what could be happening, so that there's more room to sort it out. Just like in distress tolerance, you want to stop and be able to think before you react. And this will actually also stabilize interactions with others, okay? When you stop and think, it might help you do something that's more collaborative and more constructive when it comes to other people. That's for all of us, right? And then if we have a good experience where we can think about people more benevolently and trust them more and predict how they will react to us and make bids that are easier to understand, that will give us an experience of our social world so that we can learn more from others in any environment, whether it's school, at work, in the community, in families, etc. And that's what facilitates growth over time and kind of can reverse that arrested development that people with personality disorders struggle with. Now, lastly of these specialized models is transference-focused psychotherapy, and all I'm going to talk about here is this concept of splitting. So when things are intense for all of us or heated, we have a tendency to get very black and white in our thinking. We do this all the time in politics, right? So people polarize themselves on one side or another, and there's something that helps us cope when we oversimplify things, that things are all good or all bad. But it makes us quite reactive, and it makes us prone to be adversarial with people, right? So what happens for people who have BPD with this splitting problem is that there's this one side of relationships where they see relationships as all good, where they're a perfectly cared for child with a perfectly providing caregiver, right? And then they feel a lot of longing and love. And this can happen a lot for people who have BPD. It's a myth that people with BPD never experience good relationships. It's just that there's a lot of splitting. So if Otto Kernberg is your therapist, you might think, oh great, he's gonna fix all my problems. But then he starts actually talking and he keeps things neutral so that you can think about yourself. And when you think about yourself, you might develop some negative emotions. I do when I think about myself. And then those negative emotions are perceived as coming from the relationship. So you lose touch with the sense that there's anything caring or loving about that relationship, and then you start to think everything about this relationship is inadequate, disappointing, and even dangerous. And this causes a lot of instability when you're going back and forth from a position of loving and caring and thinking things are stable and okay, to thinking things are dangerous, neglectful, and victimizing. And the person with BPD will flip-flop between these things on either end of this equation. So they may only be happy when they're in one of these idealized relationship configurations, but when they're not, they feel like everything's against them. And then they feel paranoid and avoidant, and then they miss out on life opportunities. The goal is here to help people with BPD think in a more integrated way, that the feelings that they develop are within them. They're within their psychological skin. They're within their personality processing, so that when they encounter life difficulties, there's something about them that's making them feel this way. And that people in their world are mixed. People are disappointing. They're limited. They do their best, but sometimes will fail you. But these are normal disappointments rather than dangers all the time. Now, these are just some kind of approaches that have been put out there, and we know they work, but they're very intensive. I was talking to Poppy on the way here that there's wait lists everywhere for these treatments because they take a lot of work to administer. So this is a cartoon that just kind of depicts the problem here is that this is very segregated from the real world, and some family members who work really hard, like all of you, to learn all these fancy ideas may do a great job when you're with your loved one, but then your loved one has to actually face the real world, where people do not understand these specialized concepts and won't always be able to react thoughtfully. So because this is not very well incorporated into life at hand for most people, we need to think of something more simple, something that kind of relies more on common sense. So I'm going to verge into something that's more boiled down, but just to highlight some top tips, and then we're going to take some questions. From these treatments I went over, I want you to remember that, first of all, people with BPD have emotional hypersensitivities, and they face a lot of invalidation. So what you can do is really double up your dose of validation, not to problem solve, but to help them understand what's going on for them. Because when you're on fire, it's hard to really just take stock and be mindful of what's going on. And then try to be skillful towards your goals and values and stay away from your judgments about what's going on. It's normal to have judgments, but try not to make that the basis of your operations. And lastly, try not to evaluate yourself based on the outcome of what you do, but rather on how you're doing it. This is your personality functioning. I'm just doing my best. I'm trying to be persistent. I'm standing up even though I keep falling down. These are parts of who you are as a person and what you're trying to do that you think is important. From MBT, we can think about organizing the attachment by being more predictable. We know that people with BPD will be fearful or controlling to get their needs met, and try to be clear and predictable, but sometimes disappointing, and try not to overactivate the attachment with a lot of aggression or rescue. The most important part of MBT really lies in trying to understand and convey an understanding of the person's experience, what they're going through, what they're thinking and feeling, rather than responding and taking over. And from TFP, you want to integrate the good with the bad. So try to be dialectical if you want to use DBT, but try to help the person understand that the positive and negative feelings at hand are their reaction to what's going on, and that that's understandable. And one thing that can help from TFP is this idea of taking stock realistically of what would happen if this person didn't have BPD. If you can separate the BPD out of it and just have some reality testing, it may give you some sort of grounding for where you're aiming towards, okay? Because people with BPD may be kind of so reactive and in crisis that it's hard to get your own bearings on reality and be mindful to your own point of view. And this is kind of one tip from TFP, to stay in a framework that's realistic in order to ground your own reaction to the situation. But now that we've covered all those specialist treatments, I want to see if there's any questions out here, because these are the more complicated ideas that we're going to cover today. Yes?
What if your loved one doesn't want to tell you what's wrong, and they're just in crisis mode and they won't communicate?
Yeah. Well, I think that that's a really good question. So the question was, what do you do when your loved one won't tell you what's going on, and they're in this kind of state of duress where they can't actually convey what's happening? That's a great way to start the conversation and say, I can only imagine that right now you're under so much emotional pressure that it's hard to sort out where to even begin with what's going on. How can I help you get to a place of kind of cooling down so that you can think again? And then give them space to tell you what they need. That's going to be a big theme throughout this, is giving people with these emotional and interpersonal hypersensitivities space to think. It may take a little bit of time to cool down, and what you can do to help in the meantime is offer some distractions, or offer to kind of keep them company in a way that's not just 2 feet into the crisis all the time with them. Because I think if you can give people with BPD the benefit of the doubt, sometimes they don't want to kind of get more upset than they already are when they're not communicating, and sometimes they don't want to trouble other people. But if you can kind of give them some room to kind of regulate a bit and tell you what would be most helpful, I think that's something that we need to kind of grow some patience for. Okay. Any other questions before I go on? Okay. So I'm going to move on to the simpler approach, which is called good psychiatric management. And I'll tell you the background of this. But John Gunderson, who was my mentor, he is no longer with us, but he has left behind a really important legacy of trying to teach psychiatry that patients with BPD are not hopeless and untreatable, but they're people who are not always well understood, for whom we don't always have treatments that work. So after BPD became legitimized as a diagnosis within the field, he really thought that we needed to find a way that more general practitioners out there could actually be helpful to patients. And this gave rise to this model called good psychiatric management. And the rationale for this came from a trial that was conducted in Toronto here by Shelley McMain, who is really trying to independently verify that dialectical behavioral therapy was effective in an outpatient setting. But she wanted it to be a fair fight. DBT is an intensive treatment, so she wanted to pair it up with a treatment that was informed and also conducted by people who liked working with patients with BPD. And what they found was that there were actually no differences in this treatment, even though DBT was on average 5 or more hours a week of clinical time per patient, whereas GPM was only an hour of face-to-face time and an hour and a half of supervision group. So this really was good news because it showed that with the right education and interest in the clinician, you can do a good enough job that's pretty comparable to something much more specialized, dedicated, and intensive like DBT. And this is a graph of the follow-up after 2 years. You see that there's like an elbow in these lines. After the treatment ends, either the symptoms stabilize or they continue to improve. And this is just really an illustration, I think, of the developmental nature of BPD. That once you stabilize the symptoms, you can get people back on the road of developing their normal and healthy aspects of personality so that they can grow up beyond BPD. And that was one of the questions that was asked in the Q&A that was sent to me before that I'll get back to at the end. So, of course, John Gunderson and Marsha Linehan were friends, and Marsha called John and said, "Aren't you happy that your treatment works just as well as mine?" Because that GPM approach was based on John Gunderson's clinical guide and the APA guidelines for the management of BPD. And of course, John was very mischievous, and he gloated around and said, "Haha, people don't need to know DBT to treat patients with BPD," which is actually good news. It's not to diminish DBT, it just democratized kind of access to care for both clinicians who can do their best to treat patients, whether or not they do one of these specialized treatments, but also for patients and families. So GPM just relies on what works. It's pragmatic like DBT. It uses homework, practical problem solving, and really aims patients towards getting a life that feels worth living to them. That is the cure for suicidality, is to be in the ballgame of life in a way that feels more satisfying. It uses the attention to attachment that was integrated into MBT, and the attention to social learning. What happens in our social transactions help us understand how people work. And from TFP, it really integrated the idea of splitting and attention to anger and devaluation in the relationship. So you can broadly take all these concepts that we know work and incorporate them in a good enough treatment for patients with BPD. Now, all these treatments that work for BPD have this central kind of formulation of how BPD develops and how its symptoms hang together. And the idea in GPM is that people with BPD have interpersonal hypersensitivity. They're very sensitive to what happens in relationships. So just like in TFP, there's splitting. When the relationship is going well, they can feel really stable. People with BPD will feel connected, they're idealizing of the relationship, they feel safe, but they're also dependent on the relationship. And this dependency becomes a source of anxiety. So then the patient with BPD or the person with BPD feels hyper-vigilant to what is going on in that relationship. And inevitably, because no relationship is all good, there is some threat to the relationship, whether it's real or perceived. And that puts the person with BPD into a threatened space. And they do the same things we all do when we're threatened. We become disorganized and maybe self-defeating, or we lash out of a sense of needing to protect ourselves. The difference is that this becomes so destabilizing for the person with BPD that they may self-injure as a cue for their distress in this space of threat. The problem is that the threatened state causes the person with BPD to engage in behaviors that push others away. Now, this is what becomes very destabilizing for the person with BPD, who is intolerant of being alone because they don't have a lot of confidence in their own capacity to manage, and they're highly reliant on the availability and regard of others. And it's in this state where they become more dangerously impulsive and they have difficulty seeing other people as helpful or benign. So this is where the paranoia and impulsivity set in, and their anchor in reality starts to dissolve. So this is where they become more difficult to reach because of a lack of holding. Remember, this is a kind of problem of not having that many layers of skin. So with one layer of skin, you might just start to dissolve and become leaky and uncontained. And this is where people with BPD become more seriously suicidal. If nobody cares about me and I'm to be this out of control, there is no reason to live. And so this is the state that we have to be more concerned about. But the problem with this is that in this state, signals go up, and then there's a unilateral response where people intervene and take over. The good news is that this reconstitutes a source of social interaction. So even when you're going to the hospital or the emergency room, which we'll talk about a little bit later, that actually puts you in the arena of people who are paying attention to how distressed you are. That's why there is responsiveness to these measures. But the problem is it just sends someone back into a connected state, and the cycle begins over again because they've relied so much on others to take action for them. And then there's the reliance on the relationships start to kind of take shape again. So what GPM proposes is that you lean in when someone feels threatened to help them think through what's going on to make them feel so destabilized and so worried about what's going on, so that you bring this sense of threat into a realm of understandable concern. So this is where a little bit of arguing may go a long way. If you can kind of keep your mind clear enough and focused enough on what you're trying to accomplish and manage your emotions, having a bit of intensity with the person with BPD might help you work it out. The trick is knowing how much and how to hang in there. Now, this is a part of human dynamics, and it's not just people with BPD who react this way. It's that when people feel really segregated and very unheard, they will take action in ways where they increase the volume. And it's very difficult to have a dialogue. But if something like this happens and becomes a crisis, it really gets everyone to start thinking, what in the world is going on? What are we going to do about this? And that is the constructive part of the conversation. So the goal is to get to people when they're in this kind of engaged, trusting state. Even when people with BPD are threatened, they're still trying to connect. And if you can see it that way, that they're threatened and upset about something you've done because they need you and want your help, rather than they think you're bad or they're bad, I think you might be able to manage the situation with a little bit more stability. It doesn't mean you'll always work it out, but if you see that as just part of the BPD picture rather than personalize it too much, it will help you feel like it's not too hot to handle. So some examples like this is that when I started working with John, people would be really angry at him and think he was like ruining their day or the worst person they'd ever met. And he would say things very kind of detoxifying, like, oh, they just really care about what I have to say. And I think there are two ways of seeing the same thing, is that you said something that they really cared about, so had a major reaction to. So figuring out a way through understanding that dialogue is really where GPM would point people to go. But all too often, the clinical world and others tend to intervene at this point, where the person is already too much feeling out of control to get it together to collaborate with someone that they don't trust anymore. So waiting until it gets to this point causes a vicious cycle. So the part about going to the emergency room is not that that's not helpful, but if unilateral action is always how someone solves their problem of aloneness, then they may get reliant on others to help stabilize them, and that makes them very sensitive. So in terms of relationships, John said that people with BPD will state that they grew up feeling that they did not get their needs met. And I want to emphasize that this can be true, and it doesn't mean you're a bad caregiver or a bad parent. It just means that maybe you didn't understand their difficulties, and maybe it was hard to work out your interpersonal communication so that that could have worked better. And understanding these normal failures, losses, and disappointments can help pave the way to resolution. But the problem for people with BPD is that because they didn't get their needs met, they hold on to this hope that if they just get into the right relationship, that will be a solution to all their problems of inadequacy. And that's where their interpersonal instability lies, is looking for that kind of unicorn in every relationship and being perpetually disappointed because nobody can kind of resurrect someone's self-esteem for them. So when they enter their young adult years, they try to get into exclusive relationships with someone else. And this creates a tension because that heavy of a responsibility to kind of restore a person's self-esteem and sense of a future for one person usually becomes too much. And then that other person will feel like they're getting swallowed up and they withdraw. And the person with BPD will get frantic about this. And their anxiety will take the form of angry devaluation. This is when they go from that perfectly loving, perfectly loved dyad to feeling completely victimized and neglected. And this alternates with a sense of badness. Sometimes that person with BPD will think, well, maybe there's something inherently wrong with me. And when I was a child, no one could really love me and give me what I needed. So that must mean I'm broken beyond repair. So this state of going between the idea that other people are constantly failing them or they're constantly failing at relationships is, of course, a very painful place to live. So part of what GPM is doing is to help someone understand that, first as caregivers, to understand that within our interactions with the person with BPD. So this is why people with BPD become self-destructive and self-harming. And it originally starts out as a way of coping with the sense of badness, to take the mental pain and convert it into something physical or concrete. And then this becomes a cry for help. And then people start paying attention because it becomes this cue where they know, okay, now something's really wrong in the absence of the person being able to describe and communicate what they're struggling with. And that actually ends up restoring that hope for that person. Maybe I am worth it to other people, that they do care. But this is a tenuous cycle that then goes back and forth and causes a sense of unpredictability and instability, so that the person reasonably is led to believe that they can't handle anything out there in the world. So in GPM, we're trying to teach people about this cycle so that they can intervene earlier, before things get so out of control that they lose faith in themselves and they lose important relationships, so that they have a better sense of understanding the interactions they have with others. So that when a person is yelling at you, you say, I'm scared, I really want to help you, but I can't think when you're yelling at me. Trying to give that kind of common sense feedback is really what GPM advocates, so that they can understand what they need to do differently. Like say, I just need a little bit of time to think, or maybe I need to take a walk, will you come with me? Or maybe I just need to kind of like sleep tonight and then talk about it tomorrow. And then when interpersonal interactions become more manageable and coherent, this allows the person to have more confidence to get a life. And that's what actually helps them develop a sense of self that's more clear, robust, and positive. Because after all, Freud said work and love are the cornerstones of humanity. That's how we define ourselves throughout our life trajectory. So the top tips from GPM really include things that we can all hold on to that are pretty simple and we can integrate into any treatment for any patient. I think this works for any set of diagnoses. Helping people to stop and think first. What's going on? How do I understand this? What might be going on for other people? Then you understand the interpersonal hypersensitivity and how that brings up this cycle of symptoms that seem to really be confusing and not make sense to people. When you tell a person with BPD, what you're doing makes total sense to me, it's a relief. It doesn't mean that that's what's good for them, but you can understand that there's a reason they're doing what they're doing. Then lean in when the heat is on and the anger is high, and understand anger as a normal human emotion. I think that unfortunately, like, therapists are some pretty conflict avoidant people and nobody likes when someone's upset. So it's just normal to kind of shy away from angry expressions of emotion, but we're really trying to get people to hang in there and try to sort it out through the heat of the moment. And then be careful about generating too much dependency. The problem with emergency rooms or inpatient hospitalizations is not that they don't help, it's that it keeps the patient in a passive position where they have to be contained or other people have to do things for them. That helps them restabilize, and that's okay. But you're trying to get them to understand the price they pay is them being dependent on the availability of others, so that this cycle will happen all over again once they're out of that setting. So I like to tell caregivers that the job we have that's hard is to prepare people for the sensitivities they have rather than protect them, because they are going to have to grow up and be out in the real world and manage these sensitivities on their own, and that's what's going to restore their sense of self-esteem and their sense of competence in life. You want to be realistic and know that disappointments will come up. Failures are normal. Trying to protect people from the idea that they've failed at something is actually not that realistic, because we all fail. I've failed plenty of things. And allowing them to express normal emotions that go with failure is helpful. This helps people foster corrective experiences, that if they face something they fear, even if the outcome isn't what they want, they can actually survive. People will be there for them, and they may learn from it. We want to normalize those experiences. And then you want to support your loved one in being out in the world, rather than kind of buffering them by keeping them kind of in a cave. This is something that a lot of people with BPD will end up concluding is that I'm better off just not interacting with the world. And some people will symptomatically remit that way, but the problem is it doesn't help them with their personality development, which is the core problem, is that their personalities are unstable, they don't have a consistent way of managing and coping with life, and they don't have a consistent way of interacting with people that they need. So getting a life is really important. Now, the last part of this really has to do with the idea of things being good enough. And this is an antidote to splitting, that things have to be ideal or perfect or they're not worth doing. And I have to say, in the field of treatments for BPD, I think we've kind of engaged in some splitting ourselves, that we think that you have to do this gold standard treatment that we can only treat 1 out of 100 people with in order to be helpful. I think we have to cope with the realistic limitations we all have in the world and just do good enough work wherever we are. We as clinicians and caregivers have to model for people with these emotional and interpersonal hypersensitivities, it will be okay. We all face limitations, we all wish we could do more, and it's still good enough. This concept actually came from the work of Donald Winnicott, who was a psychoanalyst, but he was also a pediatrician. And he saw lots of parents and children. And for the most part, people could grow up well regardless of challenges, difficulties, illnesses, losses, etc. And what he was trying to say is that actually he focused on mothers, but it was really about the family environment in general. He was trying to say actually families do not cause mental illness all the time. What happens is that parenting is a developmental process that has different phases throughout a person's life. So at first, actually, he thought mothers went through this psychotic period of just only thinking about their child and not thinking about their need to sleep or shower or do other things or be around adults. And actually, what they're supposed to do is over time be less and less responsive to their child in a way that the child can cope with. So the child goes from being kind of more completely taken care of to being kind of inconsistently taken care of. And they're supposed to have a good enough sense of their parents and a good enough sense of themselves to cope with the realistic limitations that they'll face in life. So what happens in this transition from a caregiver being totally organized around the life of this child is that they have to go through a disillusioning process with the child, where the child thinks the parent or the caregiving environment can do no wrong, to thinking, actually, this caregiving environment, there's some drawbacks to it. They nag me a lot. They want me to wear certain clothes or listen to certain music or keep the volume down. And these are things that hamper young people as they grow up. They have their own needs, preferences, desires, and they want to break free from the kinds of ideas of their parents. And it's that dissatisfaction and disillusionment in their caregivers, that they can't always do it right, that is the beginning of them wanting to take care of themselves and wanting to go out there. And it's in that understanding of the difference between what they want and what other people can provide that starts to draw the boundaries around the self and the identity. And that's actually really important to personality development, is the ability to cope with the disappointments you have in others and in yourself. So this really highlights this idea that we're not here to protect people from bumps in the road. We're here to prepare them that this is something that we all go through. It's difficult, it's painful, it brings up a lot of emotions that take skills to manage. But it is something that we need to think about and define for ourselves as part of our personality functioning. So across all these treatments, what they all have in common is they teach us that people are born with these vulnerabilities. They're born with vulnerabilities, whether they're emotional or interpersonal, that transact with stress in the environment to produce BPD symptoms. Those BPD symptoms then interfere with typical development. It makes growing up harder than it is for people without BPD. And then those lost opportunities in the process interrupt the person with BPD's ability to develop the emotional and social skills they need. And then they have a fragmented sense of self because they've missed out on these different parts of their life over time. So what these treatments really do is stabilize the symptoms so that they can get out there in the world. And then when they can do that, they can bridge their developmental deficits. It takes time, and we have to have patience and scale our expectations so that we let them catch up on their own terms. And that includes to making mistakes and learning from them. And those experiences will correct some of these deficits over time, and that will allow the person to develop a more coherent sense of self. I'm someone who had BPD that overcame some of my difficulties and adjusted my expectations so that I could be someone in this world. And that is really what we're aiming at here. Because for all of us, the relationships we develop with people we love in life and the work we do, however that's defined, are the cornerstone of what identifies us as unique human beings. So with that, I'm going to go to questions and use that all as a framework for how you can think about these common dilemmas. And these are questions that were sent in ahead of time, so they're coming from the audience, people who are family members trying to support their loved one with BPD. So question 1, what can a family member do when their loved ones won't seek help, but their behavior has a strong impact on all family members? Okay, so this is a really difficult one because I think if we think of this idea that I just talked about with Winnicott, I think that people with BPD are so scared to not have people have that perfect attunement and kind of attention to them that they end up in these situations where families start to kind of drop the functioning that has to do with anyone else and concentrate their energies on the person with BPD and to stabilize them. But this puts actually a lot of pressure on that person with BPD. So there is this kind of saying within the family guidelines that John Gunderson wrote for families of those with BPD, that you want to keep normal family routines and keep positive events to keep the family going. That the family is there for the person with BPD, but isn't defined by that alone. So that the person with BPD can experience their family as stable too. Having some real foundation, routines, predictability, values that stay steady and aren't reactive to these crises will help that person with BPD actually feel stabilized over time. It may be disappointing, but that disappointment will actually be a short-term price to pay for some long-term stability in the expectations between the family and the person with BPD. So when the family member wants to approach the person about getting help, it should always be from the point of view of the family having the limitations. You know, we love you, and when we see you in these crises, it really is sad and scary. And I would like nothing more for you to get help, but you need to be the one that wants that help. So that you kind of are saying that this is something you'd like to see, but you're not trying to force them into it, okay?
BPD is a disease?
Yes.
So is it different, what's the difference between NPD and BPD?
Narcissistic personality disorder and borderline personality disorder. I think the main difference is that people with BPD are much more invested and dependent on others to keep them stable and coherent. Whereas people with NPD want to keep their identities a certain way, like stable and coherent in the way they imagine it, and they're willing to distance themselves or dismiss others if other people threaten their sense of self.
The people who have NPD or BPD, they realize they have some issues, mental issues or whatever?
I think just like any other illness, some people know they have it and some people don't. It's just there's a lot of human variation to most diagnoses, but I think
Okay, go ahead.
I think that the issue is that people with personality disorders have less stable self-awareness because they're very sensitive to threats, whether it's to the relationship they depend on or their sense of self. So their ability to kind of stably understand what's going on within them is more challenged. That's a definition of the disorder. So awareness of the problem may be more difficult than for other diagnoses. But it is a medical problem. We like to think of it medically, but developmentally.
Well, I came to know from the doctors or the psychologists, they said it's non-treatable because it's a mental standing of a person.
Yeah.
So it's very hard to treat them even. If they don't realize that they are having a problem, only then you can treat them. Otherwise, this is the personality disorder, mental standing of the people.
Well, I think with any illness, the person has to know they have the problem in order to take care of themselves properly. So if you have diabetes and you don't know that you have diabetes, your likelihood of being healthy is low. So I think BPD and NPD is just like any other illness in that way, is that the person who has whatever illness it is has to be able to understand their diagnosis and be motivated to change it. And it's the clinical professional's job to present the information in a way that actually motivates hope to change. And when the professional has the attitude that it's untreatable or there is no hope, that actually influences patients to not actually think that they can get better or manage their symptoms. So it really does start with education for professionals. But I'm going to go back to this for a second, and I can entertain more questions. So how can the family member best approach the person about getting help? Like I was saying, you really want to stay on your side of the fence and talk about your experience, and then be curious about theirs. So when you're thinking about that MBT dynamic, that the person is sending distress and you're supposed to provide a understanding of what's going on for them, that's different than your own reaction. So you may be panicked and anxious yourself, but making their treatment about your panic is not really a durable approach. Telling them that you care about them and what goes on for them may get them to feel like it's worthwhile for themselves to do something that's difficult and try to seek to change. But this is a process. And I want you to think about each conversation as part of a larger discussion. You may not always get the person with BPD to move in the direction you want them to, but this is not about control or outcomes. It's about just being effective in conveying your own experience and your own feelings and wishes, and being able to accept that they're the ones in the driver's seat, not you. Should you mention BPD or not? This is actually a tricky question because it depends on the person. Just like any other illness, you want to adjust your approach depending on the person and your relationship with them. So the worst way to tell someone they have BPD is in the heat of the moment, when they're having a problem and you're trying to explain it and telling them, well, it's because you have BPD. That is oftentimes not as constructive as a kind of formal assessment and a review of what's going on and a collaborative conclusion that some of the things that the person is struggling with is consistent with symptoms of BPD. And that's generally what can happen when clinicians screen for BPD. And unfortunately, like you're saying, not all clinical professionals are informed or have the tools that would be needed to effectively treat the disorder. So I think that it depends on their receptivity. You can use phrases like emotional instability or sensitivity or interpersonal instability or sensitivity. You can use these descriptive terms to help facilitate the conversation, and then eventually you might get to a point of being able to say, well, this makes me think you may have something called BPD, which it's a really common disorder for which there are treatments, from which a lot of people recover. So offering some optimism instead of blame and kind of like accusation with the delivery of this information is optimal. So the second question is on limits. This is a great question that comes up. How do family members set limits to their loved one with BPD? How do they do so without giving an ultimatum? I think the way this question is asked is really on target because you don't want to get into unilateral action by having a standoff and saying, don't do X, okay? Because really we're trying to pay attention to people developing some agency and responsibility for themselves. So all you can do is start to disillusion your loved one with BPD by saying what you're capable of and what you're not capable of. So defining the limit based on what you can manage and what you will fail or be more vulnerable around. So being able to say something like, you know, when you yell at me in this way where you're putting me down makes it very hard for me to be constructive and supportive of you. So I just can't have that in the conversation right now because it's not helping me be helpful to you, which is what I want. So name it as your own limitation rather than the thing the person has to do. Because actually that's the problem, is that their disorganized attachment style gets into, instead of relating, getting solution focused and trying to control each other, and that only exacerbates the issue. So when you're doing this kind of process of defining your own limits, it's about putting your oxygen mask on first. That's a common saying, whether you're a caregiver or a person with BPD or a professional treating people with BPD. You have to be able to kind of stabilize yourself first and say, you know, this is so scary for me that I need to kind of ground myself, and having you do X while I'm trying to do that is just something that I can't cope with, so I'm just gonna remove myself until I'm in a better place to be helpful, but I really wanna be here for you. It's just that I'm limited in this way. I wish I could do better, but this is where I am. So that you're actually separating a statement about what you want to be doing to be supportive from what you can do. Because nobody's superhero or superhuman, and it can kind of like take you off the hook of that expectation. If this person only cares about me enough, they're gonna rise to this really kind of unsustainable standard for me. Question 3 had to do with siblings. How can parents protect and help the other siblings in the family? Siblings often witness overwhelming situations and can be caught in the middle of conflict situations. Now, this is true that siblings of those with BPD have a very complicated role, and different siblings react in different ways. Some other siblings also struggle with the same inborn biological vulnerabilities, so there may be some other siblings in the family that have other either psychiatric vulnerabilities or psychological difficulties, whether they're anxiety or kind of a need to control or have predictable situations. And sometimes they may have PTSD from having a sibling who has BPD, because it makes what should be a secure and predictable family environment more dangerous and unpredictable for them. Other siblings will try to compensate and have very few needs and be very helpful to their parents to stabilize that disorganized attachment and the attachment system of the family, and that causes them to pay a price much later. Their normal personality development is kind of interrupted by their need to be the perfect child, and then they end up having more eruptions of difficulty later when they have to be on their own and they don't know how to get their needs met. So I think it's really important for parents to really make room for the siblings, check in with them, give them time to talk. It's a hard job parenting a family when there's a person with BPD, even more so when there's more than one, but really not neglecting those who are seemingly more stable, talking to them about their own needs and wishes, but also how they're being affected. And again, you want to prepare them for what's in their life, including their loved one with BPD, and help them have the tools they may need to feel more stable with their own goals and wants in life. But this is where you can use this idea of not being perfect and disappointing the person with BPD normally as part of the process, is that sometimes you're going to have to go with the other sibling and give them some of your time and support at the expense of not totally being vigilant towards the person with BPD, because that's what's realistic and predictable for the family. And I think the last thing I would say about that before moving on is to really give the siblings some agency. Let them choose how they want to be involved, because different siblings will want different things. Some really want to be involved in helping the family through the situation, and some people will want to be left alone. And trying to respect the individual differences as much as that is tenable for you as the parents in the family is really what you have to do to sustain yourselves. Question 4 had to do with expectations and requests. How do families determine what they can ask of their loved ones? Should families let their loved ones deal alone with the consequences of their actions or choices? Like when they can't pay rent, stop going to school because they're too anxious, or lose their jobs. This is where, when I used to run the clinical programs at McLean, I really wanted to cultivate in patients the skill of asking for the help they needed in a way that got people to listen. So this is something that is short-circuited when we as caregivers try to over-anticipate their every need and try to kind of smooth out the bumps in the road. It's kind of like the helicopter snowplow parenting. The problem with that is that we often will do that for our own predictability and stability, but then it leaves the person unable to cope with those bumps in the road when they encounter them. So allowing the person with who's growing up in general, the person with BPD, to encounter these difficulties and then stop to think about what the problem is that they're having. This is an observe and describe task like DBT would do, and then figure out what help they need and what people can do for them. That's a skill that we all need in life. So being able to be in a conversation where you kind of repeatedly fall back on, is there something that you would be helped by if I did it? Do you want me to listen? Do you want me to provide advice? Do you want me to do something about it? Let me know what it is you think would be helpful, and I'll think about it and I'll do my best to respond. So being able to ask for the help you need and cope with the response that you get is something that a person with BPD will benefit from. Question 5. What can family members do when their loved one isolates, is angry at them, or won't talk to them? I think this was kind of along the lines of your question. How can family members maintain some type of connection with their loved one during these times? I think this is where you really want to think about, like, what would you want in that situation? Sometimes you might want space, sometimes you might want a different means of communicating. Just trying to be flexible and consistent is what I would suggest. So if someone's kind of staying in their room, just checking in with them at the same time of each day, even if they reject your kind of advances, if they just say no, at least they know you're gonna be there at some time every day. Or send them notes, just expressing your concern or expressing your love or support for the person. Just keep in touch in whatever way you can think of. And if they ask you not to be in touch, let them know that you're there for them when they're ready to talk to you. Okay? Question 6. What can family members do when their loved ones have created a dangerous or complex situation for themselves? Now, this is very difficult because this is something that it is normal and likely that you're going to have to react because your loved one is in harm's way. So it's normal for all of us to react to these situations and want to do something. But this is really also one of those situations where I'm going to advise you that you do have to kind of make sure the situation's safe for yourself. So oftentimes what we see in these kind of dysregulated or disorganized attachment interactions is that it destabilizes the very person that the patient needs help from. So just like you do in like some fire containment, you have to make sure that the situation is kind of stabilized, and you may do something to remove the person with BPD from the situation. And this is where sometimes hospitalization or some interruption of the situation may be warranted to just get everyone in a place where they can think and talk. But, you know, there's also this need to get outside help. You may need to call the police at times. Don't take matters into your own hands if it's going to put you in harm's way, and get the help you need to cope with the situation. But at the end of the day, I think the most important thing is that if your loved one is at risk, the most important thing is to try to keep them alive, right? So you can kind of cope with it later after you've stabilized the situation. Then talking about it later when kind of the heat and danger has died down is really what's indicated. But these situations are very hard, and the realistic limitation of it is that you can't always save the person you love from a dangerous situation. All you can do is do the things that you know how to do and get the support you need to get through it. And I know that answer is not very satisfying. There are no right answers to this. But what you do in this process is, in fact, a kind of long game. That some things have to be done short term to help you get to a situation where you can address the underlying issues, and trying to keep everyone safe in the process is the goal. But it's hard to kind of feel like you achieve that goal at times. And relatedly, someone asked, question 7, what can family members do when there is suicidal ideation and attempts and their loved one is not in treatment? This is very, very difficult, because I find that families need treaters so that they can feel like there's someone there to help, because they're family members. They're not clinicians most of the time. So it's very scary when you have a loved one that you know has some self-destructive tendencies and suicidality and a lot of despair, and they don't know what to do. And they don't want to get treatment, or they can't be in treatment for a variety of reasons. And then again, like I said earlier, you want to talk to your loved one about needing them to ask for the help they need from you and wanting to be there for them. Then express your fears and sadness about the thoughts of losing them, and your own helplessness and your own hope that there are other people that can be there for them. Because that over-reliance on one person, I feel scared that I'm going to fail you and I can't do it alone. So this is part of why I want you to have a professional on your side, so that they can use the tools and skills they have to help you find a way forward. Instead of trying to badger them into the treatment, like saying that they definitely need it, they have to do it, that they're messing up in all these sorts of ways, that kind of argument oftentimes gets very upsetting for everybody involved. And then give them a chance to express what they think. They oftentimes have reasons for what they're doing, or in the process of talking to you, they may actually kind of become more self-aware of what the problems are, what the obstacles are, and give them a chance to think it through and talk it through over time, because you really want to keep those channels of communication open, even when all these other factors are really not going the way that would make you feel more steady. But hanging in there when you feel threatened and trying to help them sort through what they're going through is really where I would advise you aim. Question 8 had to do with dwelling on the past, and I'll probably just focus on this and then take some live questions. What do you do when the family member keeps bringing up the past and telling the family member they are to blame? And what if these incidents are not actually what happened? So this can happen a lot because a lot of people whether you have BPD or not, when you're under the heat of stress and feeling really a lot of negative emotion about something, it's easier to externalize it. That's true for all of us, to blame some sort of external source. And oftentimes there is some reality that there are external factors that cause us our disappointments, failures, and losses. But being able to kind of think about, like, there is something difficult for this person to deal with, and that's why they're expressing this. So listen. And part of the conversational process is like playing a game of catch. The person is going to throw you a ball. Sometimes it's not very catchable, but you want to try to receive the message and try to understand what they're trying to say to you. I'm feeling cheated or gypped or mistreated or not given what I deserve. Whatever that message may be, it's not necessarily toxic. It just feels that it may feel very personally difficult for you because you feel you're being blamed. But being able to kind of, in DBT they may say, validate the valid. What can you understand about the situation? What can you empathize with in terms of their position about it? And then you can try to move it forward. And this is where you have to be clear with yourself about what's the goal here. A lot of families get into this process in family therapy about trying to write the record. The question is, what is